title screen? Yeah.
Yes, looks fine.
Okay. Well, thank you again, Paula, and thank you all for being here. I really appreciate the introduction and the opportunity. And I'm going to start by describing how I got to this subject. I became interested in the complexity of a key subject of this talk, that is coalescence, when I was observing at an industry meeting where physicians, cardiac electrophysiologists, specialized cardiologists learn about new gizmos. And one doctor who was speaking said, well, one way to do this procedure is to ablate or burn the antrum if you believe in it. Now, he laughed, and as a sociologist, as an ethnographer, wow, that was a great puzzle. Describing anatomy as a matter of belief. So of course I went up after him afterwards, and he laughed and he smirked at his co-presenter and said, well, it's part of the heart that's labeled by someone with a different approach to the procedure. So, among many other things, this episode taught me there are schools of thought or invisible colleges in this world of medicine, that they were engaging and they were also policing each other's practices. And that one way that they did this was through the self-conscious use of language. So I give this anatomy example, not just because it captured one of the aha moments that we field workers live for, but also because it was an example of a key concept involved in the understanding of the organization of authority and coalescence in medicine. Now, this anatomy example reinforces how medicine is characterized not only by uncertainty at the bedside, but also more broadly, indeterminacy. And what I mean by that is an ineradicable degree of disagreement and lack of clarity about what's wrong with patients, how they should be treated, and who should be responsible for the treatment. I mean, what we see in classic representations of medicine's authority, this medical theater in the Egenis painting, you see some of this, you see some kind of indeterminacy here, but you also see industry when you're looking at this more recently at the bedside. Industry is involved in defining the work and doing the training. So you have other stakeholders. Organizing indeterminacy, I'm going to argue, is a process of defining and changing the way anatomy, disease processes, and medical practices writ large should be understood by colleagues and the public. Individual physicians are actively working together in an occupational project, not only to understand medicine as it's been handed down to them, but also to construct medicine itself in light of constant social changes. Organizing indeterminacy, which involves practice of active definition, control, claims making, including labeling, advocacy, examination, refinement, and accommodation of the views of others. So just as in the Egenis painting here, they're working as individuals, but they're also collectively contributing to the practice of medicine itself. They're allowing other people to see their work and comment on it. So I differentiate this process of organizing indeterminacy from well-studied processes of managing uncertainty. Managing uncertainty is a process of working through a particular case about which one is uncertain regarding those details of anatomy, disease processes, medical practices. But in contrast, managing uncertainty happens when the work of labeling is done. It's a term used to describe an individual's state of understanding rather than the individual's work in shaping others' understanding. And that's what I'm referring to as indeterminacy. The anatomy example also raised the basic question: how does a group here, a professional group with these differences, one that's had a remarkable amount of authority, hold itself together while defining and doing its work? It ties into a theme I've been focusing on for much of my career: the social organization of physicians' adoption and coordination of work practices. Now, by authority, I use a standard definition. It's what a group has when it can keep control over what people in and around an occupational project should be doing. I'm talking about authority in a particular sense, one that has to do with management. Authority reflects these stakeholders' knowledge, their skills, their technology, and the rhetoric with those that they serve in key venues. And the reason that I see the problem of coalescence as a first-class sociological problem is, at first glance, it seems utterly impossible. People are trained differently, they have different patients, colleagues, resources in the workplace. If you break it apart, it doesn't seem like it ever could happen. But the reality is, as we study venues for different interactions, like patient consultations, procedures, professional development, conferences, that coordination seems not only to be possible, but also highly likely. And it takes us to some ideas about how authority is managed across realms of social life. Thinking more generally about occupations and venues is consistent with my research agenda. I identify as a medical sociologist, but my work is centered on social organization more generally. And I study professions, in particular medical professions and venues, to theorize about and answer core questions of social life, and to contribute to our empirical and theoretical understandings of professions, organizations, authority more generally. But I think that doctors are important in their own right for several reasons. Despite our interest in determining our health decisions, we give doctors unprecedented control over our bodies, minds, and lives. They cut us open, they prescribe potentially dangerous drugs, they perform risky treatments. We not only accept their pronouncements relative to stakeholders that range from nurses to pharmaceutical companies, but we pay high prices for their care, and we sometimes shoulder massive debt to pay off medical expenses. Although this may be different in Wales, I'd be interested in hearing more about it. So today I'm going to talk mostly about a particular question. How does a profession manage its authority? My basic argument is that one important way is through status competition. So status competition generally, doesn't endanger professional authority, but can support it. This is because in competing for status, professionals interact in periodic events in venues and use what I call tethers to connect these venues. And we can see evidence of this. In these spaces, the doctors try to manage indeterminacy by securing the status that they need to give them the authority to pronounce on it. A process that's individually competitive, but also redounds to the overall legitimacy of the medical profession. And they use tethers. I'll define tethers because they're important to this project. Tethers are linkages across venues that persist over time and are used to define and negotiate the practices, beliefs, problems, and solutions associated with a particular social projects. These tethers are used to strengthen social projects, or in Anne Mischie's terms, a group's public narratives about their existing and proposed interventions, the narratives that they must reconcile with other narratives that are being projected at them from wider social and political arenas. We can think of many examples here. A group building a political movement, for instance, they do so around a set of issues and rhetoric. Their divisions are indexed, for instance, with differences in the use of key terms, say climate change versus global warming, right? Or an ethnic or a religious diaspora community that maintains summer camps, reunions, dances, and a certain vocabulary, deliberately, say, referring to them as Iranian and not Persian. So drawing in part on the work of Edward Hughes, I'm centering on occupational projects, right? Focusing on how occupations craft what constitutes social problems and solutions while situating themselves as uniquely suited to carry out this work. To clarify that, an example of a problem might be 12-year-old has ADHD, or could be defined as a lot of energy, has a hard time focusing. The solution could be Ritalin, or it could be recess. The case of medicine, I'd argue, is particularly good for helping us account for coalescence in our new world of occupations. Its transformations are like those animating other areas of work. So when it comes to authority, it's then unsurprising that we can't tell how authority is managed, especially among the wide range of stakeholders that are involved in shaping medical work. And for more than 50 years, the assumption that we understand coalescence is clearly seen in the work of sociologists, from Abbott to Friedson to Starr. Using their historical methods, it centered mostly on licensing and analysis of professional associations. These scholars have largely described professions as having distinct boundaries from other professions and from industry. They secure boundaries by creating barriers to access that close their ranks. They strengthen boundaries to generate political influence, and they co-opt external stakeholders into the project's boundaries. So in addition to credentialing and other modes of boundary making, we've also assumed authority is managed by a kind of once and for all socialization in medical training. So since the work of Robert Merton, we've largely assumed doctors get the white coats, they take on a set of similar values and practices. And we see that assumption taken up in many areas of sociology, right? Including, for instance, the study of organizations. Socialization is a key element of the initial formulation of isomorphism in organization theory. To be sure, when we look at the work itself, we do see boundaries are somewhat constitutive of an occupational project. But at the same time, they're also permeable and they're secondary to the work that's actually getting done. Here in this slide, we see an attending or a faculty physician, the fellow or one of the trainees, and also the tech. But we also see an industry rep from Medtronic. And so for me, one of the catalysts for studying the area of cardiology in the first place was that one of the first observations of a procedure that I made, the industry rep was actually teaching the procedure to the physician. It was nothing like the kind of socialization that we see in our literature. And the boundaries are porous at the annual meeting also. So one of the key focal points of these fascinating venues is the exhibition hall, where you have physicians and industry all mixing. There are many other examples that we can see in our literature, right? There are chaplains and TSA employees work interdependently, much more so than if they saw themselves separated by professional boundaries. Tech companies, data scientists, just like in the way that Medtronic will sponsor fellowships, Cisco will sponsor computer science RA-ships. And this is especially true in law. The state will co-opt lawyers in efforts at economic development, and some of the highest status corporate lawyers work in accounting firms. So having a boundary doesn't equal having coalescence. To study coalescence in a way that accounts for boundary spanning work, it's important to examine moments, venues, where and when workers will execute their tasks. In fact, to look at events. So this work is continuous with recent research on events, but I'm not using so much the historical, but rather the ethnographic definition of an event. So I'm going to suggest that examining events and venues, the meetings in specific places where people gather around a task, that can help us see endogenous processes, contrast to the exogenous factors of credentials and so on. After all, medicine involves many tasks, from patient care to knowledge creation to presenting research to engaging with a hospital or another workplace. These tasks occur across venues. And so to get at coalescence among individuals who come together or intersect across venues, we need to understand how these venue-based tasks or the events where they happen are linked or tethered together by participants. Let's see how well this works. Oh, great. So this was one of my first attempts doing ethnography with a GoPro camera here. It's unusually flashy for an ethnographer, I know. But these doctors, they love the new gizmos. So when in Rome, I try. So I'll tell you a little bit about these specialized cardiologists or cardiac electrophysiologists. They do a couple of things. They implant pacemakers or defibrillators. Actually, here we are, one right up there. They also burn or ablate arrhythmias back into normal rhythm. Their work involves a very fast feedback loop at the bedside. They'll burn a part of the heart and see if the arrhythmia has been fixed. Then they'll repeat. It's very different than doctors, GPs in general internal medicine who can just do nothing. And sometimes that solves the problem. They're also unlike general cardiologists who may give their patient Lipitor or another drug and tell them to come back in three weeks. In many ways, though, the task of managing arrhythmias, they're much closer to the pilot who has to land a plane in a thunderstorm. They have to act. So for these doctors, who I'll often call EPs, good hands are important, right? But also good eyes, they say. Studying these physicians connects to work that I've been doing on individual level status. The professions literature is all about the status of the profession itself and the subfield, but only in passing do we learn about individuals. Work on status is usually experimental, focused on nominal traits. Some of those experiments do involve tasks, so it gets us a little bit closer. But what we see in the field and in others ethnographies, in professions, individual status is multi-dimensional. It's not simply tied to organization prestige. That's an assumption we often get in the organizations literature and the work of Podolny and others. It involves these multiple qualities. So to see that, we need to go to different places that are set up for different tasks. Doctors meet in these different venues, and there's a challenge there in doing this work. The challenge in ethnographically studying events outside of the face-to-face situation is in demonstrating their penetration in a particular time and place. After all, participant observers, we gather data by personal interaction. And if you do shop floor ethnography, you're going to see situations. So after all, it makes sense. Ethnography is an ethnography of particular actors in a particular social space at particular social times. So what we need then is a way to show how phenomena occurring in other venues can exist in the one that we view. I examined a set of tethered venues outside and inside of what I'll call Superior Hospital. I studied 6 venues over 6 years, and I'll discuss 3 today, but I can discuss others in the Q&A. I chose these venues by looking at where physicians went, but also by examining ethnographies of medicine, seeing key places where these doctors work. And it's a good case at EP, I'd argue, because it's a small world. Constant observations taking place, people are observing each other in their labs, and they're constantly meeting and discussing others' practices. So we begin in the home lab. Since EPs are at the end of the referral chain, they're dependent on referring colleagues, right? So patients referred by other EPs, ones that have made their way through the GP to the cardiologist to cardiac electrophysiologists, and then referred to other cardiac electrophysiologists because they're a really tough case. They serve as tethers that allow the highest status doctors, so we call them standard setters, to take on the toughest cases. They may publish on their experiences or enroll patients in a clinical trial, but in either case, they make the field look good. They strengthen the occupational project. What one of them said was, reputations could develop solely by your outcomes. successful procedures are expected. Most of the time you go in, you should have a greater than 90% chance that you're going to succeed. And in medicine, it really ought to be that way. We should not be taking patients when on a consistent basis, they have a 50 or 60% chance of success. They're concerned with strengthening the occupational project and getting good outcomes. This was very striking for me in the beginning. Their major concern is not for the patients, although they may care, but especially their personal reputation. It's very much consistent with a common saying, right? The patient died, but the surgery was a success. These doctors want interesting cases, in part to discuss in their morning meetings among lab members. There they'll describe interesting cases using slides. And they tether venues by sharing these slides across different spaces and circulating their findings. As one of them, Dr. Malcolm, said, we often make PowerPoint slides using published articles. And when we use other people's work, we credit the people when we show it. Some people ask me for slides. Recently, I wanted to show a slide of a colleague in Europe. I put not only courtesy of Bill, but I called him specifically, sent him a copy of the slides, and said, can I show this slide of this information? Are you okay with it? Just having the slide at all is a sign. It says, I got this slide from Fred Malcolm. I'm his best friend. He laughs and says, yes, it's a signal. A lot of that happens. There's a whole process of making sure people know that you are in the know. So about 75% of the talks that I attended inside and outside of the EP labs included other doctors' slides. And as the quote indicates, having them at all serves as a signal. The person's doing well in a status competition. So I also went to industry-sponsored events. There, standard setters will present their research. They'll show how to use new technologies as well. The clinicians will go to the company headquarters. They'll listen to lectures from the standard setting doctors, and they'll actually do a procedure on a mellow animal, usually a pig or a hound, it turns out. I'm circling here the slides. As I mentioned, the speakers will share the slides that they use with other standard setters. And at these events, what we see is that clinicians will work with standard setters in an apprentice-like way. It's just like in their fellowship. And the speakers there might gain access to patients that can help them help the profession. It obviously also helps them improve their status. They can write up these cases and so on. As one of them wrote, I don't know what the honorarium is for this stuff, but it's the same as it was 25 years ago. These meetings help you build things. So I was referred a patient this week from Paris, and the guy said, go back to Chicago and follow up with this guy. And he knew me. So it's not that you care about your status in terms of your reputation as much as you do your status in terms of spreading the gospel. By gospel, he's referring to the idea that EP and maybe his approach is a solution to problems like that of the patients. They want to have a global presence, and they want to make it so EP is the field to send their patients. After all, there are competing professions that have similar jurisdictions, like cardiac surgery. So they're attending the meeting not just for money, which is unsurprising given what we know from Weber on legitimate authority, but also to strengthen the occupational project. The clinicians, the practices that speakers discuss here also become considered the standards for what clinicians consider to be the best thing. And by clinicians, I mean the everyday doctors, right? Everyday doctors in Poughkeepsie. So, the speakers' practices the clinicians will take notes on their talks. Those clinicians will go home to their home lab after the event and try them out. And as one fellow said, so if you're going to learn entrainment, you go and you learn from these guys. If you hear Jeff Moore speak in these meetings, You can check that off of your list of things you need to get before you can say, I'm trained. You can make the literature searches and read the articles, but those are the certain people that you know you need to learn certain things from. So these top doctors' practices are actually accepted on the basis of their status. And so I asked this fellow, what percentage of these gurus' articles will you read? And Joe quickly responds, very, very few. He said, if here they say ABC and I go to my lab and I see a patient and I do my thing and go, oh, it's ABC, no reason for me to read their articles because what they tell me is working. But if I go to the patient and it's like ABD, I think, okay, I missed something. I got to either go call them, email them, or go find an article and read it and bridge the gap, figure out what I missed. Consequential information then is communicated in these events. These standard set ideas are consequential. They change what the next generation is socialized to see and also shape their ideas of the field's norms about right and wrong. The doctors are resources who use their talks as tethers that make the practice efficient. And also they're doing work that's changing things periodically. So others can figure out how to practice differently by calling them if necessary. Finally, at the annual conferences, a lot of attention is focused on research presentations. But a focal point is what's called the live case presentations, where a distinguished doctor, sometimes from a different country, will go through a tricky case live. These doctors shift linguistic registers. They're talking to the colleagues in the crowd in different ways. What's common there are footing shifts, right? Instances where communication and social relations come together. And ultimately, they're nodes between venues. They use linguistic tethers, using their terms for what's going on. They actually engage in a kind of wine talk, like the Guardian magazine articles whose subtext is, you can understand wine, but not without me. Beyond those live cases, the doctors will present their findings, right? They know the audience is taking pictures of their slides. You know, I'm sure regular practice in your undergraduate lectures happens with me all the time. Not exactly. They use these slides as tethers. They're enhancing speaker standing and diffusing their findings. So of course, I went up to 4 or 5 doctors and asked them why they were doing this. This was puzzling, right? These images just came out in the New England Journal of Medicine. Why would you be taking pictures of them? So in definite contrast to my undergraduate lectures, they share these images with colleagues, right? They use them to inform practice and strengthen the case with their hospitals for making capital investments. But as in sociology conferences too, there are parties, right? In these social events, you've got standard setters promoting their confederates while disparaging those who appear to be doing bad things for the field, like making up data. So these are from my field notes. One doctor contrasts the practices in his home lab with those of a doctor whose practices have received scrutiny in recent years. He says, I never quote Pantos's data to patients. I quote our success rate. It's basically 80, 70, 60, and that's very basic stuff. Pantos, everybody knows he makes up his data. 5,000 cases and no strokes, the complication rate should be 0.5%, even if you manage things correctly. The way we do it is like a textbook. So we see this policing happening over and over in social events. The labs will host events every year among alums and potential recruits. And here the doctor uses these numbers as a tether, promoting his own lab. He's also aware of the damage of misleading expectations for the occupational project. Here, I also served as a tether in these meetings. The head of the superior lab would introduce me as someone who could give positive accounts about the lab and how humane they were to their fellows. In these events, the fellows will come back and they'll talk about the good old days in the lab. So this is also from my field notes. Clinician Dr. Marcus is describing how a standard setter, Dr. Bunton, foresaw a widely publicized failure of a new technology. He points to Dr. Bunton and says, this guy was clairvoyant. We've been burned a few times by new technology, and we're a little bit wary. I have no doubt that having suffered the Metastar fate recently, we will all do it again. Dr. Bunton smiles, offering history repeats itself. Dr. Marcus says, absolutely, because companies come up with a reason to sell the story to us that we should be putting them in, and we don't have time to wait. Everybody wants to be the first 100 to put them in. After working with Bunton, you know how many of those leads I've put in? 3. When Dr. Bunton replies, history repeats itself, he identifies himself with an elder's wisdom in the field. He's willing to be critical of the newest technology, and he also demonstrates his ability in foreseeing problems. He has the judgment and insight, and he's going to tell others about it, especially in light of the damage that was done to EP by the lawsuits and distrust following the technology failure that's being discussed here. Later in that conversation, Bunton goes on to talk about how he counseled the advisory board not to make such thin leads. In sharing his observation, he reaches outside the field's upper echelon and can begin gaining the benefit of the doubt. Then doctors and community hospitals will be especially grateful for his foresight and communicated insight, and they'll have less access to comparative information they tend to have less access to this kind of information on technologies in the hospital that they work in daily. So here I demonstrated evidence of status competition and strengthening the occupational project, how doctors carefully cultivate relationships, how low status actors accept standard setters accounts simply because of their high status, and the self-promoting gossip in which doctors point to others' past transgressions. Yet a stronger argument for this association is to examine an association working in reverse, a time when status dropped and the occupational project was damaged. So I'm going to talk about a case in which the Superior Hospital doctor lost status. The hospital instilled a rule in which, in trying to control admissions, it limited referrals into the hospital. Consequently, these would-be referrers ended up unable to transfer Medicaid and uninsured patients into the hospital. So for the unfamiliar, Medicaid is a public health insurance program, one that reimburses the hospitals much less per patient, per procedure than Medicare, which is one that is intended to for treatment of the elderly. Medicaid is intended for the treatment of people under the poverty line. So Dr. King tells me about this event. I apologize for the amount of text here, but it's important. So he says, we've already gotten burned. Phil Cavins is at Methodist Hospital. He called me and said, can you see this guy about a defibrillator? Well, he probably should send that patient to county hospital, but there's reasons he doesn't. Because he's afraid that they're not going to get good care, or this patient might have to wait 6 months. I say yes, then I get a phone call from the chief who tells me that I need to call Dr. Cavins back and say, I don't need to see his patient. So then the patient gets the message that we said okay, and then we said no. And I'm the messenger for the hospital. That's the worst part. And then they have a national meeting in town for the Association of Black Cardiologists. And in front of all these cardiologists from all over the country, Phil Cavins stands up and says, I can't get my poor patients care even at Superior Hospital anymore. They said they'd see a patient and found out he has Medicaid, and they won't see him. So that would-be referrer publicized this instance of institutional racism at the annual meeting of the Association of Black Cardiologists. So they lost patients that might have served as tethers and raised their standing. And as I mentioned with venue one, they want to have enough patients so they have some choice. They want to have at least a 90% success rate. And at the same time, in not helping their colleague, not simply taking all patients in need of medical care, indeed appearing to discriminate, they dented the occupational project. It was damaged so much that to salvage their standing, they left Superior altogether and moved to a lower prestige hospital and department. So we can see this event then as part of a sequence of event ordering that involves the diminishing of individual status and coalescence. Medical authority is organized not only through doctors' similar socialization processes or gaining through credentials or licensure, but also because they strengthen the occupational project as they compete for status. The venues and the case study showed that status competition involves participation in repeated venue-based events and the use of tethers. It involves ongoing endogenous practices and processes that contribute to the strengthening of the occupational project. In terms of status competition, we saw the creation of strategic alliances, efforts to influence visibility, the protection of one's standing. These repeated events allow people to develop and strengthen ties to show their different skills and capabilities in a range of domains, from surgery to teaching. And the use of tethers affords doctors the opportunity to establish their practices as authoritative and also set reachable expectations. There's a competition for status among EPs that determines who can sit in influential positions as guidelines committee members, as principal investigators, as keynote speakers, and so on. This competition shapes who has the right to establish both the profession's key problems of concern, such as atrial fibrillation, as well as its solutions, medications, devices, ablations. This competition operates across venues. These include the lab, hospital boardrooms, industry-sponsored events, annual meetings of professional associations. Medical authorities maintain through this status competition. It's a process that helps establish what counts as up-to-date knowledge or best practice at any particular time, and also serves to protect the profession's authority by reinforcing the fact that it can meet public expectations. So a central finding is that the leadership structure among physicians is multi-headed, characterized by a governing plurality, where it's possible for different approaches to exist. It's a non-zero-sum competition. And the second finding is that multiple non-physician stakeholders in an occupational project play important roles in a process of organizing and determinacy. By focusing on exogenous processes, boundary creation, the use of credentials, makes it maybe easy to overlook that an occupational project depends on the ability of people involved in the project to develop a whole process of working together. And by focusing on work itself and across venues, it highlights the range of what individuals are doing in the competition. It also reinforces that status competition allows for the social control that's necessary for the profession to further the occupational project, because it motivates and facilitates their monitoring of what others are doing. It thus connects people in a way that represents coalescence. There are some scope conditions of my argument, which will hold more strongly in some professions than others. So case studies in the ethnographic literature show this in some professions, status orders may be partially mediated by bureaucratic controls that diminishes the possibility of coalescence. You have elementary and secondary teachers, school teachers, the military, some areas of engineering, nurses, social workers, librarians. Also, in some professions, coalescence might be more closely associated with a different relation or orientation, like consensus. right? A strong union presence might lead professions to coalesce around principles like economic security. It's also been argued that the authority of the clergy depends in part on collegiality. And so beyond the initial model that I've sketched here, there's likely to be some variation. Also, I focus more here on standard settings, standard setters, through interviews. In my other work, I showed their interdependence with clinicians. I'd be happy to talk about this more in the Q&A. So these findings suggest the limits of reducing the way that authority is managed, especially as it relates to so-called external stakeholders, to simply a story of either professional supremacy or corporate capture. Let's see. On one hand, Andy Abbott in early work would say that a professional group would co-opt those that have different expertise into their group. Bruno Latour, in his case study of Pasteur, described a similar co-optation. But physicians' relationship with industry involved much more dependence. They depended on fellows programs and industry meetings to build networks and learn skills, as well as to provide a visible venue for demonstrating the merits of their approaches to organizing and determinacy. These same device reps helped standard setters keep new technology from the hands of the inept. On the other hand, in the literature, Conrad and Light, they point attention at corporate capture, a situation where prevailing problems and solutions are established by private corporate interests, which differ from those of physicians. But physicians were frequently taking control of their clinics and even venues that were organized by companies, while companies put meeting agendas and invitees in the hands of physician program directors, and device reps sought to distance themselves from physicians whose use of their technologies put their own and their company's reputations at risk. So ultimately, this work confirms that industry reps and medical professionals mix in interdependent ways. So while sometimes industry is kept at arm's length, some other times it facilitates self-governance in the occupational project. So what we've seen is a multi-headed mode of governance that's characterized by mutually beneficial relationships. Authorities is not managed by professionals or industry alone, and that fact, rather than being understood as separated by boundaries, should be understood as a hallmark of sharing an occupational project. Studies like this, I would argue, also provide some important general insight. There's an ethnographic literature that would show that status competition in coalescence is limited because it largely focuses on single venues, right? Certainly for professionals in new fields like data scientists, there's strong interdependence with industry, meetings in different venues, standard setters, and so on. And for those in older professions like chefs, we know that there's a similar status competition. And finally, scholars of culture have shown that coalescence accompanies this competition, though among chefs, it comes through sharing. Right? For instance, this seems to be the case with techniques for molecular gastronomy, which I guess is now called modernist cuisine. And a look outside of the literatures in work and occupation shows us that this relationship for status competition and coalescence works outside of professions, right? So we can see this relationship holding in community studies of immigrant enclaves like the Polish community in Chicago. And there's stratification among EPs, finally, organized in part by referral networks. These doctors may have been trained similarly, but as their careers have progressed, they've become differentiated in terms of having different patients, propensities for research, and set of work tasks. This stratification system functions to protect the field. Those clinicians who prefer simpler cases get them and are successful, while referring the more complex cases to the standard setters who value them for research and status. And in part because of the complexity of the standard setters cases, and because they may learn about and also develop technologies with industry, they're better apprised and able to use the cutting edge technologies. So this interdependence, in theory, minimizes failure with the potential to hurt medicine's authority, and also provides cases to standard setters who can publicize medicine's advances. And what it shows us is that many of the qualities that help workers coordinate in one venue actually have to do with activities in other venues, whether it's a mode of talk, interpretation of data, an approach to choosing what work to undertake. And because all this can be said to repeat across venues, to further the occupational project, we could say that these endogenous processes are associated with coalescence. Thank you.